A very good evening to you. Welcome to this live forum on NTV. And given it is the month to raise awareness on cervical cancer, that is what we're discussing this evening. I have quite the eminent panel with me, knowledgeable from different facets of things. And first, to a man who is no stranger to these studios, virtually or in person, Dr. Githinji Gitahi, who is not only the group CEO of Amref Health Africa, he is also, for the purposes of this conversation, the chair of the National Cancer Institute of Kenya. He'll be telling us a little bit about what they do, what their purpose is, but generally coordination, you know, oversight, putting it in a few words. And we also have in studio, you know, Benda. I was like, did I read it right? Is it Brenda or is it Benda? Benda Kithaka, and she is Kilele Health Executive Director, and she's also the lead Africa Cervical Cancer Alliance. Good to have you in studio as well. We have Zipporah Kalama, and she is a cancer survivor, and she'll be sharing her experiences with us and where the gaps exist, what needs to be addressed with urgency, and what gains from her experience have been made. And also in studio, Professor Omenge Orango, and he is a gynecologist. He's also oncologist, right? An expert as in the field of cancer. But I've been told, somebody whispered in my ear, particularly in the area of cancer that affects women. And he is also the chair department of OBGY, Aga Khan University, that is obstetrics gynecology, Aga Khan University. All right, and we begin the conversation with this, Dr. Gitahi. I read in my research that sub-Saharan Africa has the highest burden of cervical cancer. For those who may not be too familiar, though, my understanding, Prof, you'll correct me if I'm wrong, cervical cancer is a growth of abnormal cells at the entrance to the womb, the cervix, correct? Okay. All right, so for those who may not know exactly what cervical cancer is, that is what it is. It affects, I said womb, so you know it affects women. And but before we get into the risk factors and all of that, this highest burden sub-Saharan Africa, what do you think that is about?
Well, thank you for having me here. And on behalf of the National Cancer Institute, which is a semi-autonomous agency of the Ministry of Health, and our role is, as you say, to coordinate, but also to advise the Ministry of Health on cancer matters and coordination, looking at quality of care and all those things. I'm glad Dr. Mwenge is here for all the clinical conversations. But as you've explained, cervical cancer generally, before I go to Sub-Saharan Africa, is the leading cause of cancer cause of death for women in Kenya.
Leading, I thought was second.
It is second in terms of number of cases, but in terms of death, it kills more than breast cancer. Now, that statistic is not only in Kenya. Cervical cancer is also one of the leading causes of death for women across sub-Saharan Africa, across the African continent. We say that 9 out of 10 cervical cancer deaths will be in low-income areas. That is Africa, Asia, South America. So it's not just about Africa, which tells you that actually is related to socioeconomic status, literacy, and availability and access of quality health services. Because those areas I've talked about are the ones in the world that have the lowest coverage of health services. So therefore, it is related to this system problem of low investment in health services, lack of access to screening, early diagnosis, people not getting what they need at their primary healthcare center. So that is why the continents that I've talked about have the highest burden. Number two is that, and I'm sure Doc will add, is that there are other risk factors that are associated with cervical cancer. HIV is one of them. So continents and communities that have a high incidence of HIV will also have a high incidence of cervical cancer. But for this conversation, I would like to limit it to low health investment, not being able to get women to be screened on time at their nearest location and put on treatment. Therefore, low screening is actually, I would say, the largest factor in causing sub-Saharan Africa to have the highest burden of cancer deaths, cervical cancer deaths.
Low screening. Low
screening and poor early diagnosis and poor putting on treatment. The screening rates in Africa are very, very low. In Kenya here, you know, you look at people who've been screened the last 3 years, if you ask, you know, spot checking, maybe Doc has better statistics, I would say 7 to 10% of women would say have been screened in the last 3 years, 10% or less than 10%. Now the target is 70%.
Yes.
So you can see how far we are. And when you're not screened, it means you don't know. Even the number of cases we announce, which are probably slightly above 5,000 a year, new cases, are underestimate because we don't screen. We don't screen people. And people finally end up in hospital, not because they're going to be screened, but because they have symptoms. By the time you get symptoms, you're talking about late stage, in which case then your treatment is more complicated. This is why cancer deaths in Africa are so high, largely because of the failure of the health system, which is related to the socioeconomic status and also the low investments in health services. Maybe the final point to close is, when we talk about low investments in health services, it is related to the affordability of our tax base. If you look at Europe, they spend 400,000 Kenya shillings per person per year on health services. Yeah,
400.
4,000. Yes, 4,000. Yeah, about 500,000 per person per year on health service on average. Here in Kenya, it is 4,000 per person per year. When you average the total amount that goes to the health services and you divide by the population, you're talking 4,000 versus 400,000. So there is low investment generally, and that's across the continent of Africa. So that is part of the contributor, which means you can invest in screening and early diagnosis and nurses and doctors and oncologists and all these other systems that are needed to actually reduce the burden. So those are the complexities other than the other risk factors I talked about, like HIV.
Okay, and we'll come back to access and equality, because this administration is keen on UHC, universal health coverage, and preventive care. So you advise the Ministry of Health, you said so yourself, as the National Cancer Institute of Kenya. So where this is concerned, what advice are you giving? We'll come back to that. We'll come back to that. Prof, there's something Dr. Gitahi raised, and that is, what does HIV have to do with cervical cancer? Because I was reading an article that was actually published on your website, the Aga Khan University, and they talked about HPV, that 99% of cases of cervical cancer are caused by the human papilloma virus. They mentioned two specific strains, 16 and 18. Now, HIV again.
Okay, that's a good observation and a good question. Cervical cancer, virtually all cervical cancer, is caused by infection with a virus, human papilloma virus. So we know that that is what causes cervical cancer. This is a sexually transmitted infection that is very rampant. It's very common. It is estimated that by the age of 50, about 80% of women would have been exposed to human papilloma virus. So it's a very common virus in circulation. There are those that cause cancer, the human papilloma virus that cause cancer. So they are called high risk because they cause cancer. There are those that cause other things, but they are not cancer. It's called low risk. So the 16 and 18 you mentioned are the leading causes of cancer. So human papilloma virus is there are many, over 100 subtypes that cause that infect human beings. And so out of the many, about 100 or over, the 16 and 18 cause over 70% of the cancer of the cervix. But there are others that cause that. So there are about 12 or 14 subtypes that cause cancer of the cervix, but the majority are then 16 and 18. What happens is that majority of the women would clear, human beings would clear HPV from their circulation. Many of the women get infected at the start of their sex debut. So they will get it, they'll clear it within 2 years by their own immunity. The people
It takes 2 years to clear the system?
Yes, on average.
Okay.
So they clear it. The ones we get worried are those who get infected, but it persists over time. So one gets infected, and by 4 years, 5 years, it's still there. So what it does, it then manipulates the cells of the cervix and stops them from growing the normal way. You know, we shed cells from our body every day, every so often, and new ones grow. But if this infection goes into the cells that regenerate, but then it stops them from growing normal, they become abnormal. They start growing without stopping. That's what a tumor is. So it causes that on the cells of the cervix and starts growing abnormally. And therefore, that's how cancer comes in. The HIV-infected women, you asked how now?
Yes.
Their immunity is not as good, and therefore they are not able to clear HPV as people who are immunocompetent, as people who are not infected. And therefore, we know for a fact that HIV-infected women will have the HPV persisting for longer. They will have multiple high-risk HPV types, unlike the HIV uninfected people, and therefore, because of that, they will tend to get the tumor, the cervical cancer, at a higher rate than the HIV uninfected. So that is really basically the reason why HIV infected would be at higher risk than HIV uninfected. But by and large, in terms of absolute numbers, of course, the HIV negative women, because they are more than the HIV infected, would be having cancer of the cervix. But if you were to look at the proportion of HIV infected women with cancer as opposed to the proportion of HIV negative women with cancer, the HIV infected ones are overrepresented because of that.
Okay. Well, Benda, I'll come to you now. There's a screening that Dr. Gitahi talked about, because my understanding is this is an entirely preventable cancer.
Absolutely.
If you get the vaccine, if you go for screening, regular screening, and the prof will tell us what is regular for which subpopulation. And so, you know, you can treat the precancerous lesions. If it's caught early, it has a success. You can treat it successfully. But are there other factors that contribute to women in sub-Saharan Africa not accessing screening services other than access?
So I will go back to what Dr. Gitahi spoke about. He talked about socio-economic situation that we have in sub-Saharan Africa that would lead the woman not being able to access these services. And that comes to health system strengthening.
Oh, sorry, and the reason I asked her that question is because she works in the communities. Community advocacy. So,
yes, I do. So working with communities, one of the reasons why we see women not showing up in good time is actually fear and stigma, okay? And I'll explain that. If we are saying it's preventable, we're saying easily accessible, the HPV vaccine is available here, it's free of charge. We're saying we have screening modalities that are available here, but only 7 to 10% are taking up that service. Then you can imagine the ones who are presenting late stage will be presenting when they have the signs and symptoms, when they have invasive disease. And the ultimate is we find many of those women do not make it to their 5-year survival rate, okay? And that is the saddest bit. Now, in our communities, we are socialized not to talk about death. Secondly, we are socialized not to discuss things that would potentially bring about death. And cancer has been seen as a death sentence. Yet we know cervical cancer is not. And even most cancers are not death sentence if discovered early.
but you know,
So-
I usually say, I would
Yes.
not wish cancer on my worst enemy. And the reason I say that is because it's so expensive to treat. And then most times it's got late.
And we'll talk about that. But if you consider the fear and the stigma that I'm talking about, it's even what you're speaking into. That late diagnosis leads to invasive treatment modalities, leads to death in the family, leads to impoverishment. Because if, as a mother, I'm going to think about my children being left without their caregiver because of fear of cancer, I will say but that which I don't know about. But what we are here as the community advocates, activists to bring about is that women need to change that paradigm. We need to change that perception completely to get women to understand that we have the power to prevent cervical cancer. One, it's a procedure that takes about 15 minutes in the doctor's office, and I'm counting 15 minutes from when you get into the doctor's office to when you get prepared for that screening, if it's a pap smear, to when you actually finish getting the sample taken and dressing up again and leaving that doctor's office. 15 minutes of discomfort, if there is, and yet women are dying of a disease that's preventable. Secondly, we also have screening with self-sample collection, okay? Again, fear and stigma, because we have not invested as the health system enough in that preventative model, and it's still new to many women, self-sample collection. In the privacy of your bedroom, in the privacy of your washroom, you could easily take your sample, drop it off somewhere, and get screened and know whether you have the high risk that he was talking about. So the fear and stigma, I tend to say sometimes it's unfounded. However, even as we're talking about fear of cancer, stigma of cancer, it's also about what Dr. Omenge spoke about. We are continuously hammering it that it's caused by multiple reinfection with HPV, which is sexually transmitted. And yet we know, because it is so common.
Wait, when you say multiple reinfection, you mean multiple sexual partners?
That's
Simply
one of the
put.
risk factors, but I want to demystify that for everybody. It's not that the woman has been promiscuous or unfaithful. It could be that her husband or her spouse or whoever has had sexual relations could potentially have had multiple partners. They bring that HPV to that marriage. So instead of stigmatizing women and bringing fear to the woman, we're saying let's focus on what we have control over. Control over is vaccination for our girls before they get into having intimate relations. If we do so, we're helping them prevent. It has been proven in Canada, it has been proven in Australia, Germany, and other countries that are high developed, that if you vaccinate girls today, in 15 years, we'll see less of cervical cancer in this country.
Okay.
Secondly, educate women.
I just want Zipporah to comment, because she can speak from personal experience on
Yes.
this, and there's some significant things you said, which I'll ask Dr. Gitahi to also come in on, which is, you said it's free, the vaccine.
Yes, it's free.
Where can whoever is watching take their daughter or their sister to get this vaccine? And then also you talked about sample collection, because the idea of going to his office to Zipporah, labda utueleze ulikuwa diagnosed na cancer lini na ulikuwa umeenda screening au?
Asante kwa kunipatia nafasi hii. Kwanza wacha nishukuru Mungu kwa kunifikisha hapa leo.
Amina.
Nilikuwa diagnosed 2019 March. Nilikuwa niko na bleeding, continuous bleeding for over 2 months. Sasa nikienda hospitali ninaambiwa ni early menopause. Nikienda hospitali ninaambiwa ni early menopause because I was more than 45 years. Sasa nikaenda, lakini bleeding haishi. So nikaendelea kutibiwa, nikaenda kwa CT scan. Wakanambia ni inhormonal balance. Bleeding haishi. Napewa dawa, bleeding haishi.
Na sasa umeenda CT scan?
Nimeenda CT scan. Alafu ndio nikaona bleeding haishi. Ndio sasa nikaona afadhali nifanyiwe screening. Sikuchelewa, nikafanyiwa screening pale Kilifi Hospital. Sasa ndio nikaambiwa niko na cervical cancer. From there nikaanza matibabu pale
Moja, vile uliambiwa uko na cervical cancer.
Yes.
Ulisikia kama roho yako imeshuka au?
Nilisikia I am a mother of 2 boys. I love them. Mahali walipo wananiona, ninawapenda. Nilikuwa ninafikiria tu ndio nikifo hivyo, ndio nimeacha watoto wangu hivyo. Watoto wangu watakana nani? Lakini nikajitia nguvu, Mungu akanitia nguvu, nikamove. Nikaenda sasa kwa treatment pale KCH, nikawa referred kwa Mombasa Cancer Center, nikaenda kuanza chemo pale. Kwa sababu nilikuwa nimeanza bleeding kwa muda mrefu, HB yangu ikawa imeshuka sana to 6. So sikuwa naweza kufanyiwa chemo. Nikafanyiwa
transfusion. HB inamaanisha nini?
Damu yangu ilikuwa iko chini, kiwango changu cha damu kilikuwa kiko chini. So nikafanyiwa transfusion, nikaanza chemo. Nilienda 5 sessions of chemo, then nikakuja Nairobi nikafanyiwa radiotherapy. 20 sessions of radiotherapy. Shida ya matibabu ni ghali. Because
nilikuwa nataka kuuliza, ulikuwa na NHIF au ulikuwa na
nilikuwa na insurance. Lakini sasa insurance itakulipia nusu, then hiyo nusu ingine unajaliza mwenyewe. Haiwezi kukulipia matibabu yote ya session moja. So ukienda kwa session wanakulipia nusu.
Tuseme kama chemotherapy. Ulisema ulifanya session 5?
5, yes.
Moja ni pesa ngapi?
Around 40,000.
40,000.
Yes.
Kwa hivyo unatoa kwa mfuko 20,000. Na hii 5 sessions unaenda kwa muda
weekly? Yes. Mara moja kwa wiki, it was on Friday.
On Friday.
Yes.
Na walisema lazima uanze immediately kabisa,
immediately. Sasa nilichelewa kwa sababu ya HB yangu ilikuwa iko chini. So nikachelewa kidogo hapo mpaka nikafanyiwa transfusion. Halafu niko blood O negative. Ambayo si rahisi kupatikana. So lakini nikafanya bidii nikapata. Nikawekwa na nikaanza chemo. Sasa Mombasa kukawa hakuna radiotherapy. Sasa ikabidi nikuje na
Ngoja, Mombasa yote.
Mombasa yote kulikuwa hakuna by 2019. Yes. Nilikuja nikafanyiwa hapa Nairobi.
Ikabidi tena uingie kwa mfuko
Nikuje Nairobi.
kuja Nairobi.
Yes. Nikafanyiwa hizo 20 sessions of chemo, of radio, sorry.
Wait, 20.
20. Yes.
So 5 chemo, alafu
20.
tena 20 radiotherapy.
Daily. Radio is daily.
Na hiyo session moja mpesa ngapi? Hiyo
10,000.
2019 ilikuwa 10,000.
Yes, that time ilikuwa 10,000.
Unalipa nusu.
Unalipa nusu tu. Insurance haiwezi nilipia yote. Kwa sababu insurance yangu, job group yangu iko chini. Yes. Sasa ni mfuko alafu uongezewe. Nikaenda for the 20 sessions za radio. Nashukuru Mungu nilimaliza vizuri. I was very healthy. Hata ulikuwa ukija pale kwa radio, ulikuwa huwezi fikiria, nilikuwa niko na sistangu hapo. Sistangu kidogo ni mslim. Mimi kidogo niko healthy. So hata ulikuwa ukifikia pale kwa radio, unaweza fikiria yule sistangu ndo amekuja kwa radio. Because nashukuru Mungu kwa sababu sikuluzi hata weight hata. Niliendelea na hayo matibabu mpaka nikamaliza vizuri. Nikarudi Kilifi, nikaendelea na shughuli zangu Kilifi.
Uko clear sasa, uko sawa.
Niko sawa. Naendelea pale Mombasa Hospital, kila mwezi naenda kwa kliniki pale Mombasa Hospital.
Haya.
Kuona daktari pale.
Tutazidi
Kuna
kuongea
Dr.
na
Riaz
wewe.
pale.
But thank you for sharing your experience, Zipporah. Nataka tuchukue break kidogo, lakini tutarudi na nyinyi wote.
I don't think you understand. I'm running out of time. I don't think you really know. Not enough time for you and me.
There's a kind of bank assurance intermediary that really allows you to relax because you know you'll be good. That's Coop Bank Assurance Intermediary for you. Get covered real good through Coop Bank Assurance Intermediary.
Lakini vile hii ekonomi imetufinya, ilinibidi kubadilisha sabuni nikatumia ingine rahisi. Bala, ilibidi nioshe kila kitu mara mbili. Sikuwa na otherwise, nikarudia Ariel.
Ariel, usafi bora kwa mwosho mmoja tu.
Warembo, ni nini muhimu kwenu mnaponunua body lotion?
Smoothness, scent, glow.
Nunua Nice and Lovely body lotion. Inai-transform dry skin kuwa deeply nourished na kui-smoothed. Na fragrance nayo, wacha tu.
Now available in the 850 ml pack.
Chagua Kenya's #1 body lotion.
The baby I'm expecting is yours.
You better start telling yourself that I am not going to give you a single cent.
This is your child.
Why were you looking through my computer files? Who else saw them? Answer me.
Your grandfather. That's the reason why he had a heart attack.
Have you seen the old man? Yes, the best thing could happen is for him to die.
What did you just say, Rodrigo?
You heard me.
Head over heels.
Join the Optivan family today and experience the epitome of coastal living at Ocean View Ridge, Vipingo by Optivan. Call us on 0790 300 300.
Optivan, Optivan.
Panda tukupandishe on Go Entertainment this new year on Go TV. Bila kulipia extra. Furahia the best sports, international shows na local shows una like free. Download Go TV stream. Go TV. Love it.
Thank you for staying with us. We have a live forum on cervical cancer. The purpose is to raise awareness, which is also part of the mandate of the National Cancer Institute of Kenya. We have the chair in studio, Dr. Githinji Gitahi. So there is a target the World Health Organization set. 90, 70, 90 by 2030. 90% women screened. You mentioned that earlier because you talked about 7% in sub-Saharan Africa. The target is 90 by 2030. 70% vaccination. Then 90% in terms of the treatment of the pre-cancer lesions and the management of cervical cancer. Where are we as a country?
Well, we are far. We are far. As I said earlier, screening is 6-7% depending on what you're looking at. If you look at longer, maybe 5 years, 10 years, there'll be more women who will say yes. But if you look at a shorter period, you know, what you call recency, then maybe 3 years, you have lower numbers, about 6-7%. When you talk about vaccination and, you know, HPV vaccination, which I would like to emphasize and re-emphasize and re-emphasize is the most important investment that we can make. I saw a study today, I think from Ireland, that says that they tracked women who got their HPV vaccine at 12 years, and that they have not seen evidence of any cervical cancer in that cohort. 0. So HPV vaccination is the most important, but has to start early. We have to start early. So the study was talking about 12 years, okay? We have to start early. Why so? Because as Doc said, it's about the HPV virus. Now you want to develop the immunity before the virus, before you get the virus. You don't want to give the vaccine to somebody who's already infected. It's kind of a waste. The efficacy is very low. This is the reason why we emphasize on actually giving it to school-going children. Early on, 12 years, 13, 14, by 15, actually you should get 70% of 15-year-olds vaccinated. And that, we saw pushback by certain communities sometime when this was introduced in 2019. And we must re-emphasize to our people that we are talking about lives and health. And lives and health are also God-given. And knowledge is God-given. So we can't push back and put lives at risk and have communities that are told by some other communities that don't allow your young children to be vaccinated because they're not sexually active. They will be. And you want them to actually be vaccinated before they become sexually active. That message must be sent, and because of that message not having seeped through, and because of that early opposition, you know, today the Minister of Health, the Cabinet Secretary of Health, Susanna Kumicha, was in Taita, and she was talking again about this, and we're talking about how to actually ensure we have HPV vaccination centers across the counties and pushing through so that girls are vaccinated. Now, the importance of this is that when you do that, all these costs that Priscilla is talking about, Zipporah is talking about, disappear. You don't have to, you know, to do all these tests, all this brachytherapy, all this radiotherapy, chemotherapy. We can actually achieve, and that 90-70-90 strategy is for cervical cancer elimination. We can eliminate it from the face of Kenya completely if we allow our children to be vaccinated. We are working as the National Cancer Institute with the Ministry of Health, with the Ministry of Education, because school-going children are part of our biggest cohort, but whether to vaccinate them in the school or in the public facilities or in private, that is within the strategy. There is something that Benda said, that this vaccine is free, completely free. Right now, Kenya gives 2 doses. In other areas now, WHO now is saying we should move to 1 dose. There's, you know, Omenge can talk about that and what evidence available, but we are now moving from 2 doses to 1, but for Kenya it's still 2 doses, okay? This is the biggest investment we can make. Now let me talk about very quickly about why this is important. We have said that we as a country, because of our economic base being low and our tax collection being low, we cannot afford to chase cervical cancer treatment with money. We can't afford it. You've heard. The best investment we can make today is 2-pronged. 1, vaccinate every girl by 15, achieve 70%. Secondly, invest in primary care screening, not level 4 and 5, not the big hospitals. Invest in ensuring that women are screened at primary care, and they are screened and treated. Not just screened and told, go now, look, because the navigation journey, I'll tell you that women who come to the hospital at stage 3 and 4 will tell you, and we've heard from Zipporah here, they have been, on average, there was a study saying they have visited a health facility 6 to 7 times. Can you imagine? We had here that the first treatment that she was given when this continued was a CT scan. Nobody, for goodness sake, decided to do a pap smear. Nobody decided to do a vaginal examination. We have a problem of over-medicalization of our health system. I met a lady the other day. She told me she was pregnant. She had no idea. She went to a facility with swollen leg. She was admitted for 2 weeks. She was told to go home. Nobody had done a pregnancy test. Nobody had asked her when her last menstrual period was. So we have to go back to the basics, which is why the strategy on community health promoters is important. The strategy on ensuring primary health care networks in the counties is important, but that's not only enough. You must ensure the money shifts from the high-level hospital, secondary, tertiary, and a significant part of it goes to ensure when you go to a dispensary, which is level 2, you go to a health center, which is level 3, you can get a pap smear, you can get cryotherapy, you can get those basic tests that are needed for cervical cancer that are identified and treated at that facility at the pre-cancerous level are what we need to invest in. Not to wait to invest in cancer centers and then wait for the women to come and then we spend millions on this money. We should shift the money to prevention.
Makes sense. Sorry, Benda, you have something to add to that?
I would actually say don't just take it to the facility, take it to the community.
He talked about the CHPs.
Yes, take it to the community and get that infrastructure so well connected that the woman can actually be able to test, to screen at her home or even as close as possible, so that we're not having to tell women, stop what you're doing to go get screened at the facility. Some of them are caregivers. They are in running small businesses. They are running their life. We should make it so women-centric that women can actually prevent cervical cancer at the touch of a button. That's how easy it should be.
All right, so we need to take a break for the news highlights. But Prof, when we come back, several questions for you, including, so one of my questions was tonight was, is there a less invasive way where you talked about the self-sample collection? Also in terms of vaccinations, how far have we come? Because I know we've talked about the 7%.
That actually, if you look at double dose, the 2 doses, it's about 33% so far. But if you look at many of the children, no, it's about 16% double dose. Because the people who come for the single dose, many of them fall out. They don't come back. Facilities are far, challenges of transport, community connectedness. So when you look at
also, which is why the
vaccination,
WHO is pushing for the 1 dose.
Exactly. So we end up with only 16% if you look at double dose in Kenya.
All right.
Very low.
So WHO is not pushing because people are falling off. It's because of the evidence that was generated by research that shows that 1 dose is as efficacious, that it is successful as if you give 2 or 3. So let it be that people don't think we are pushing poor medicine for poor people. No, it is that there is evidence, and Kenya was part of the study fields that contributed to the study that now strongly advocates for single dose.
Yeah, but the policy for Kenya is still 2 doses for now. But that's where the science is going.
Yeah. So we'll take a break, but we'll come back with my panelists on the other side.
And we need 2 Royco cubes because iron gives you strength to sukuma yourself to be the best you can be.
I trust Sunlight 2-in-1 washing powder to give my clothes a sensational clean and an uplifting fragrance. Sunlight. More than you expect.
Warembo, ni nini muhimu kwenu mnaponunua body lotion?
Smoothness, scent, glow.
Nunua Nice and Lovely body lotion. Inai-transform dry skin kuwa deeply nourished na kui-smoothed. Na fragrance nayo. Wacha tu.
Now available in the 850 ml pack.
Chagua Kenya's #1 body lotion.
This is NTV.
Tonight,
No sign of War Memorial Hospital. Nakuru County government takes hospital battle a notch higher days after a hostile takeover. Also tonight,
saa hii tumeanza square one. Hakuna chochote hapa. Watoto wetu wako chini ya miti, walimu wako chini ya miti, hakuna ofisi, hakuna chochote.
El Nino aftermath. Learners sitting on stones under trees in Tana Delta. Plus, Nairobi's revenue collection system. Governor Johnson Sakaja and MCAs in a push and pull over the city's billions. And
na alitoka tu nyumbani akiwa ametumwa dukani, lakini hakurudi. Akagojea na nyanya yake akakosa kukuja.
Anaonekana alikuwa anajidefend, but huyo mnyama juu, huyo sio mwanaume, huyo ni mnyama. Amemtega kitendo na akaacha kama amemua.
Another missing woman and a dumped body. Who will stop the killings? Kiambu in mourning.
Stay 5 degrees cooler.
Body odor is caused by germs, and on active days, the sweating and odor are more. That's why you need the new improved Dettol Cool with up to 5 degrees instant cooling sensation and odor protection. Be Dettol sure.
Who is a true partner? They go out of their way to help you. They do not hesitate to go the extra mile. And they're always there standing beside you. They step in when you need them the most. Because a true partner is a partner kwa ground. KCB Bank.
Panda tukupandishe on Go Entertainment this new year on GoTV. Bila kulipia extra. Furahia the best sports, international shows na local shows una like free. Download GoTV stream. GoTV. Love it.
All right, we are raising cervical cancer awareness this evening, and Prof, I have a couple of questions for you. So first of all, if I get the vaccine, because there's a case study that Dr. Gitahi referenced from Ireland, do I also need to go for regular screening? And what is regular screening? Because the WHO guidelines are between, what, 35 and 45, at least 2?
Yeah, so that's a good question. If you have been vaccinated, do you still need screening? Yes, you do, for the following reason. Remember that we've given you a vaccination. The vaccine that we have initially started with the quadrivalent. The ones quad means 4, covers 4 types. Now there is the one that is nanovalent, covers 9. But remember, I said that the high-risk HPVs are up to 12 or to 14. So we may have given you a vaccine and you're protected, but who knows? The other minor that were not the majority, the leading in causing that, who knows? Once the immunity comes up, we might start seeing other subtypes causing cancer. The good thing is that the Scotland study that came out on 22nd of this month, that was published, did say that they followed those women, and in that cohort, nobody has had cervical cancer. Beautiful. Then it means that possibly there is cross-protection. Cross-protection meaning you have immunity against the ones that you are vaccinated, but you also have immunity against the other ones because they did not see any breakthrough cancers. So yes, it is possible that in the long run, we might realize that once you have been vaccinated, you don't need screening. But the knowledge we have, the information with us now, it does make us say, yes, you'll be vaccinated, but you continue having screening. Screening, vaccination and screening are 2 tools that we have that are very important, that we need to emphasize. Vaccination Remember, in our country, we're only vaccinating girls. By the way, the boys also need to be vaccinated. The most successful, like the Scotland that we are quoting, vaccinate both boys and girls.
Really?
Remember, HPV does cause other cancers other than cervical cancer.
Yes.
Today, we are talking about cervical cancer. But there are other cancers. There are head and neck cancers. There are anal cancers for the men who have sex with men. And for head and neck for both men and women. And therefore, as we fight against cervical cancer, we don't want to see a situation where then there is a blow up of the other cancers that are associated with HPV, and yet we have the ammunition of vaccination. So in reality, we should, I've heard this argument by countries that want to spend little, that, oh, let's give the vaccine to the most affected. Because cervical cancer is killing so many women, let's just give the girls. The boys, there's not too many rectal or penile cancers that we are seeing. We are seeing more head and neck cancers. And so if we leave these boys behind, we will have another battle of cancer that we would have otherwise used the same vaccination, same strategies, and reach to both. So vaccination is very important and key for this war. Screening. Remember, there are women who may not have gotten the vaccine. So this cohort of women will have to screen them throughout. And therefore, we will still have to combine vaccination and screening. I want to go back to what we said about screening. We've talked about self-sampling. Remember, self-sampling is for you to test the high-risk HPV. However, there are even other cheaper strategies that have been there.
Really?
Visual inspection with acetic acid.
Oh, okay.
Just putting vinegar. The regular vinegar in the supermarket, 5% vinegar that we use. Just apply it on the cervix, and the nurse or
At
a
a
medical
health
Kenya.
facility,
Yes.
please, people.
Yes.
People who know what they are doing.
Yes, no, yeah, in the health, not at home. I'm saying at a health facility, by a trained person to do that.
Yeah.
They apply for a minute or so. They look. If there is a problem, it turns white. If there is no problem, it's okay. If there's a problem and turns white, that person has a gadget that has been given called cryotherapy or called coagulation, which they put on the cervix. It freezes it for 3 minutes. It has killed those cells that will become cancer. The National Cancer Institute has partnered with other providers, other development partners, and has provided those gadgets in many facilities in the country. We want to talk about rocket science, but we know that we have other things that we can easily use. They are there. We want to urge our women.
There's no blood test, because to be honest with you, even me, Prof,
no.
As I sit here, you tell me I go to a doctor's office and expose myself essentially to a stranger.
Think about what she said. If you actually get the cancer, what does it really mean to your loved ones? What does it mean to the little children that you leave behind? Evidence available suggests that a child whose mother dies never gets full potential of what they would have gotten in life, both growth-wise and what they would have achieved in life. If your mother died when you were in class 5, for example, it's very unlikely that you would be at the position which you are in. So you can imagine the ripple effect death of one mother does to the children, to the society, and the cost of treating cancer itself. But if you went there and you are seen and something is picked early, you save this country money, you save your family the trouble. Remember that when a woman has invasive cancer, there are many things that happen. She is exorcised because she can't attend chamas, she can't go to church because she bleeds, she smells. If you walked to Kenyatta National Hospital, for example, and you blindfolded me, take me to the gynecological cancer ward, I'll tell you I've arrived. Why? There's a characteristic smell. That thing dehumanizes you. A woman with invasive cancer of the cervix dies a dejected life, a very dehumanizing life. Do we have to do that now? No. Why don't we borrow from countries that have done things that work and we know they work? Why are we hiding our heads in the sand? Because that's how things are done? No, we can change.
Okay, and just for public information, you talked about the foul-smelling discharge, you talked about the bleeding, pain in the lower back, in the pelvic area, but usually in the initial stages, the precancerous lesions, I read there are no symptoms, and that's why screening is so critical.
Yes.
Okay, and sorry, just one more question, Benda, to Prof. you've heard these stories. Zipporah says they did a CT scan for her before somebody thought to do a pap smear. Was it a pap smear? No, it was a vaginal exam. Dr. Gitahi has talked about a pregnant woman, swollen feet, hospitalized for 2 weeks and nobody tested for pregnancy. These doctors you are training.
So let me tell you, that is her case is a typical case where the system, the healthcare systems, failed a patient.
Yes.
And we have replicated that many times. This is cervical cancer, but the other conditions that we've replicated the same, where, as Dr. Gitahi said, somebody spends a lot of money by the time a diagnosis is done. What is the reason? He said we've medicalized the system, and we think by having high-end technology, cutting-edge technology, is when we fought cancer. I remember very clearly when a PET scan was installed in one of the institutions in this city. It was said they have as a machine that fights cancer, which is a lie. A PET scan, for example, helps you monitor a patient once you've found that they have cancer and you've treated them. Having high-end technology like PET scan is not what will clear cancer in this country. Simple things: screen these women with acetic acid, do pap smears, vaccinate the girls with the HPV vaccine. Not the high-end technology. High-end is a good feel thing. We agree. You then start saying, oh, we are developed, we are like Europe, we are like... That's lying. The basic, even Europe that has reduced their instances, they started by screening. They have a good system of screening, tracking patients, encouraging them to go for care, take your blood pressure, simple things that prevent. It's not the
And
machines.
Dr. Gitahi has been singing this song for the longest time. Benda, you wanted to add something before we each comment briefly on way forward?
I want to bring the attention to men as well. You know, we are continuously talking about the woman, the girl, the woman, the girl, and we are forgetting that men also have a role to play, and not just men, but the entire of society approach to cervical cancer elimination. Because when we talk about community engagement, we're saying here men are in positions of leadership. Most of corporate Kenya has quite a number of men in senior positions, yet we find that in private sector women are not also going for screening, yet their insurances can afford it. They can be able to afford that treatment if they get caught early. And yes, we're still finding women in corporate Kenya that have invasive cervical cancer. So men need to take leadership positions as well. As we're encouraging women to go and get screened, let men provide an enabling environment. Let me put it to you. Most places of worship are led by men. Most places in the community, the chiefs, the different areas of administration, where they have the ability to bring as many people together as possible, they're led by men, isn't it? So men need to be educated that cervical cancer is not just a woman's disease. When that woman loses her life, the society has lost a pillar for the family, for the community. And therefore, men need to be invested in this conversation as well. Okay. In leadership positions, at the community, in different places where we can talk to women about screening, let's talk to men about enabling environment for women to be screened, including providing resources. For example, many women will tell you, I needed to ask for permission to go for screening from the man in the household. Let the man know this is not a question of discussion or bargaining. This is, my woman needs to be screened, okay? And not just the woman in my household, my sisters, my cousins, my friends, my relatives, every woman, and therefore every man has a responsibility. And this is an Africa-wide conversation because fear, stigma, taboo topics about women and reproductive health, all these are conversations that need to be had by both the head of the family as well as the women in the community, and getting our girls vaccinated as well.
All right.
Yeah.
So we've already touched on some of the way forward, but if there's one message you would not want to leave this studio without passing, what would it be? For example, Dr. Gitahi, the Institute talks about the cancer strategy is centered on research, you know, some of the interventions that you're proposing moving forward to the Ministry of Health, data-driven.
Yes. I think a lot of the conversations we've had here are actually data-driven. The question is how specific and context-specific is the data, meaning that we have to do our own research which is why we are happy that we are working with universities and KEMRI and others. We have to do our own research so that we, even as we pick the research out there, we have to contextualize it. So that's what the National Cancer Institute is doing. I think this week we are launching actually a call for grants, for research grants for different people. And some of the areas we are looking at is why do we have such poor HPV vaccination penetration? We are looking at local data, so we are generating that. Secondly, we are using this data to inform the development of the UHC policies and strategies. We know now that Kenya is moving from the National Hospital Insurance Fund to the Social Health Authority and Social Health Insurance Fund. We have input into that strategy to say, for example, pap smears were never covered by NHIF. True, Benda? Now, they were seen as routine tests. Can you imagine? Yet, a prostate test for man was considered covered because it's not routine, yet it should be routine. Every man should go for PS. It's just a poor understanding. So now we made sure that things like screening are now part of the Social Health Insurance Fund. They're going to be covered. And we see that as a good movement forward. So data is important for us to inform our UHC strategies. And that's what we're investing in. But we are not doing the research ourselves as NCI. We are coordinating the centers of excellence that exist, either private or public. The most important thing is that we have data for our people that the government can use to shape policy for the betterment of Kenyan people.
All right. Zipporah, na wewe kama kuna kitu tu moja ungetaka kuambia watu leo?
Ni mbili.
Mbili, aha.
Naomba uniruhusu niongee mbili.
Lakini kwa kifupi?
Kwa kifupi. Naomba serikali iongeze hizi hospitali. Because kama ni Makadara peke yake in Mombasa ndio inafanya radio. Ni wamama wangapi watafanywa radio kwa siku moja? So ni vizuri pia serikali iangalie katika zile hospitali zingine kama vile Malindi, kama vile Kilifi, waweke chemotherapy, waweke radio. Kwa sababu hata mama anaposcreeniwa akipatikana ako na cervical cancer, je, ataenda wapi? Kama hana huo uwezo wa kumove kutoka kule aliko mpaka Nairobi, wacha apate matibabu katikati ya yale maeneo anayoishi. Halafu japo la pili, nataka niambie wamama wapime. Ukiacha watoto wako kama mama, kama hujapima kansa ikubebe, unaacha watoto katika hali ngumu sana. Kama vile daktari ambavyo amesema, mama ni kiungo muhimu sana katika jamii. So, ninataka ni emphasize on that, na pia niseme kama unaishi na virusi, kuwa priority kupima kansa ya kizazi.
Aya. So naomba msamaha Benda and Prof, please allow me to close because the news must start on the dot, Benda.
I have a challenge for you.
10 seconds.
This conversation should not only be a January conversation.
All
this
right.
conversation with the media so that you can reach more people all year round.
So a challenge accepted. All right, with me in the studio we've had Dr. Githinji Gitahi, National Cancer Institute of Kenya Chairperson, Professor Omenge Orango, who is a gynae oncologist, chair department of OBGY, AKU, Ms. Benda Kithaka, who is Kilele Health Executive Director, Lead Africa Cervical Cancer Alliance, and Zipporah Salama, cancer survivor.